Today we're tackling how drugs actually work inside the body. That's pharmacodynamics.
Exactly.
You look at the mechanisms, how they do what they do, and also what factors can change their effects.
Right. It's really aimed at giving a clear handle on the basics, especially helpful if you're, say, a medical student trying to piece this all together.
Definitely. It's about moving past just the drug name to the how and why, the molecular action, and how well people differ.
Precisely. So pharmacodynamics, what is it really at its core?
Okay, so fundamentally, it's the study of what drugs do to the body, the effects, and how they do it, the mechanisms.
And why is that understanding so vital?
Well, our sources stress a few things. One, it shows us how drugs chat with our cells, basically. Two, it connects the drug dose or concentration to the effect, finding that sweet spot.
More isn't always better.
Exactly. And third, knowing this helps us use drugs smarter, tailor therapy for patients.
Makes sense. And drugs have, well, quite a few tricks up their sleeve, right?
Right.
Different ways they work. Our sources lay these out nicely. Let's start with receptors.
Right, receptors. Super important. Think of cells having, like, tiny docking stations on their surface.
Okay.
Drugs can fit into these. Agonists are drugs that bind and flip the switch, activating the receptor. Morphine binding to opioid receptors is a classic example. It activates them, reducing pain perception.
Got it. And the opposite.
Antagonists.
Yeah.
They bind, but they just block the spot. They don't activate anything. They just stop the natural chemical, or maybe another drug, from getting in.
Like putting gum in the lock.
Sort of, yeah. Okay, next up, enzyme inhibition.
Ah, yes, enzymes. The body's little catalysts, speeding up reactions.
Right, and some drugs just get in the way. They inhibit specific enzymes, slowing down whatever reaction that enzyme controls.
Like aspirin.
Exactly like aspirin.
Yeah.
It inhibits an enzyme called COX, cyclooxygenase. This reduces the production of prostaglandins.
Which are involved in inflammation and pain. So less prostaglandin, less pain.
Precisely. Then there's ion channel modulation.
Okay, managing the flow of charged particles across cell membranes.
Yep, ions like calcium, sodium, potassium. Their movement is key for nerve signals, muscle contraction, tons of stuff. Some drugs can open or close these specific channels.
Calcium channel blockers are a good example here, right? Like amlodipine.
Perfect example. They block calcium channels in heart and blood vessel cells. Less calcium gets in, muscles relax, blood pressure goes down.
Controlling the gates, essentially. What else?
Transporter inhibition. Cells have these proteins, transporters, that ferry substances in and out, like tiny shuttles. Some drugs block these shuttles. SSRIs, antidepressants like fluoxetine, they block the serotonin transporter in the brain,
Just serotonin can't get taken back up into the nerve cell.
meaning more stays active in the synapse, which helps with depression.
Clever. Okay, is that all the main mechanisms?
There's one more broad category.
Yeah.
Non-specific actions. These drugs don't seem to target one specific receptor or enzyme.
Ah, like general anesthetics.
Exactly. The thinking is they might just sort of interfere with the cell membrane itself, the lipid layer, especially in nerve cells. This leads to that overall nervous system, depression, loss of consciousness. It's less targeted.
Okay, so a range of strategies, from very specific lock and key stuff to more general effects. But it's not just about the drug's mechanism, is it? The patient plays a huge role.
Oh, absolutely. Factors modifying drug action are critical. Let's talk patient characteristics. Age, for one.
Yeah, babies and the elderly often process drugs differently. Metabolism isn't the same.
Right. And weight obviously affects drug concentration. Dosages often need adjusting. Then there's genetics.
Pharmacodynamics, how our individual DNA code can make us respond differently to the same drug. It's a massive area.
Huge. And then what if someone's making multiple drugs?
Drug interactions, big potential issue. One drug can mess with how another is absorbed, broken down, or removed. Sometimes effects get boosted, sometimes reduced.
Like antacids interfering with some antibiotics.
That's a common one, yeah. Simple but important. And of course, the patient's overall health matters.
Definitely. Like liver disease or kidney problems can seriously mess with how the body handles a drug.
And environmental things. Food, maybe?
Yep. The classic is grapefruit juice affecting certain drug metabolizing enzymes. Alcohol, two dangerous interactions are possible with many meds.
And we can't forget compliance. Does the patient actually take the drug as prescribed?
Crucial point. If you don't take it right, it won't work right. Even when you take it can matter.
Right, like some blood pressure meds working better at night.
Okay, so just to recap quickly, we've got pharmacodynamics, what drugs do and how. Mechanisms like receptor binding, enzyme inhibition, ion channels, transporters, and non-specific actions.
And then all those factors that can change the outcome. patient age, weight, genetics, other drugs, diseases, food, alcohol, compliance, timing. It's a lot to consider.
It really is. Understanding all this is just, well, it's fundamental for anyone involved in prescribing or managing medications. It's about safe and effective treatment.
Absolutely foundational.
Which leaves us with a thought, maybe for you listening. Given all this complexity, all these individual variations, how close are we, really, to truly personalized medicine, where we can reliably predict and tailor drug therapy based on someone's unique profile?
That's the big question, isn't it? What's the next leap forward going to be? Fascinating stuff to think about.
Indeed. Thanks for diving into these core principles with us today.